A very good morning to all of you. Uh, Welcome to today's webinar on critical review of India's progress towards tobacco smoke-free public spaces and workplaces as per the MPOWER measure. We have very eminent speakers today. We have Dr. Rakesh Gupta, who's from President Sipher, and Dr. Kanika, who will be talking about the critical review part. And then we have Dr. Rana Singh, who is the Director, Southeast Asia Tobacco Control from Whitefoot Strategies, to give his expert opinion on the progress being made. With that, I would welcome Dr. Rana and Dr. Kanika to please share their thoughts on the presentation. Uh, so over to you.
Yes, Dr. Kanika. Kanika? Yeah. Next, please.
Yes, sir. Introduction is done by sir.
I'll be introducing the topic. Yeah. Next, please. So, global tobacco burden. It is about 8 million people. They're claiming their lives every year, and about 1 million, more than 1 million deaths, they are directly linked to secondhand smoke exposure. Secondhand smoke that contributes significantly to respiratory illnesses, the cardiovascular diseases, cancers, and creating affordable suffering. The impact extends beyond health, placing a heavy strain on healthcare systems, and it also causes economic losses worldwide. Next, please. So we have a WHO MPOWER strategy to control tobacco. In 2008, the World Health Organization launched the MPOWER strategy. It is a 6-component framework to curb tobacco use. The protect pillar that calls on countries to ensure that smoke-free environments in public places, workplaces, and even the public transport. And WHO emphasizes that laws alone are insufficient. Effective protection requires strict compliance and enforcement. So I think these are the keywords: the compliance and the enforcement. Benchmark is, as per WHO, it is more than 95% compliance rate, though in India we have reduced it to a bit. Next, please. India's legal response is India responded through Section 4 of the COTPA, that is the cigarettes and other tobacco products, and it is supported by the prohibition of smoking in public places. This is the Section 4. And these laws, they define public spaces, mandate signage requirement, specify penalties for violations and designated smoking zones. Though the penalties are not much these days, because the law was passed in 2003. So considering that in 23 years, there has not been any change in the fines. Smoking zone exists in airport, hotels, restaurants, and despite these measures, the violation that persists due to unclear statutory responsibilities, limited enforcement powers and training, penalties, they are too low to deter the offenders. Next, please. Compliance is the critical measure. The compliance reflects the real world enforcement of the smoke-free laws, not just their existence on paper. WHO global data that shows that indoor compliance averages 52.7%. The outdoor compliance drops to 26.5%. And the hospitals, they fare better. The compliance is about 58%, while public places remains low. To achieve 95% compliance benchmark, we need to strengthen the penalties to deter the violations, clarify the laws and responsibilities for enforcement agencies, and engage communities and raise awareness about second-hand smoking dangers. In India, the hospitals and schools, they show stronger compliance, but restaurants, offices, and transport terminals, they lag behind the GATS data. The transport terminal means basically airports and other transportation modes. Next, please.
Objectives will be covered by me, Kanika. So what's inside cigarettes? So the main objective of the study is to examine legal and policy evolution of smoke-free public places and its regulation, which is in India. To see the existence compliance levels across categories of public places and workplaces by using available service and observational evidences. To formulate actionable recommendations to identify the structural administration and behavior barriers to full implementation. The last objective is to benchmark India's progress against the WHO Empower P criteria and compare countries. The material methods. So first, in material methods, there are the research processes. So first is the data collection. In data collection, the data of GATS, which is Global Adult Tobacco Service, were taken. WHO reports were taken into consideration. Compliance studies were taken. Government and NGOs reports were also taken, like from the data of the union and the vital strategies. Then there was in a process of screening and selection, in which a clear abstract clear abstract title was chosen, and then a full text evolution was done. Then there's the data extraction, in which biometric data related to the secondhand smoke was taken into the considerations and findings were made. Then there was an analytical approach. Then the last procedure was to find the conclusions and the recommendations which were given. The data, which is mainly taken as GATS data, which is Global Adult Tobacco Service, it's data 1, which is of 2009 and 10, and GATS data 2, which is of 2016 and 17. Then there's Global Tobacco Epidemic Reports, 2008 to 2023 were taken into consideration while making the PPT and the study. Then there was a peer-reviewed compliance studies were taken, observational mixed methods audits of COTPA section 4 to 10 were taken across various venues. Then there was National Tobacco Control Program and grey literature, which means the ministry's websites, state health related issues, NGO reports, and conferences. Then there is a criteria process, which is eligibility criteria and selection process, in which it is further divided into two sections, which is inclusion and exclusion. So in inclusion, there was national service, example GATT survey, which is a standardized secondhand smoke exposure, peer-reviewed studies, government reports, and legal text. Then there was an exclusion criteria, in which excluded studies, which is the lacking outcome data, were taken into the consideration and prepared and looked after it. And there were two. Screening was done in two stages: persist title, then the full text review. Then two reviewed works worked independently. Then comes the third last slide of material methods, which means this figure summarizes the methodology used to review smoke-free law implementation in India. It includes 5 stages: data extraction and management, where study characteristics, outcomes, and limitations were systematically collected. Then there comes the quality assessment, over where evaluating the risk of bias and confidence of each study was taken. Then there was quality assessment, in which it was evaluating the risk of bias and confidence of each study. Analytical approach, which was the fourth process, using quantitative, qualitative trend methods to synthesize data. Last Last is the overall purpose to provide a comprehensive and a reliable assessment of India's progress in implementing smoke free laws and to guide future tobacco control efforts. There comes a slide 15, which states tobacco smoke free jurisdiction. Over here, a picture is inserted, which which is a which states the data of a smoke-free jurisdiction. There should be a comprehensive legal ban of smoke in all indoor public places and transport hubs. Rules should be uniform. There should be a regular inspections on penalties should be there. Over there's also a photo provided by the vital strategies, which states that Shimla is declared smoke-free. Then come to the next slides, which which is a slide depicting the graph in which India's smoke-free journey is given, in which jurisdiction declared smoke-free and estimated population protected from harm of second-hand smoke. Over here, we can see that in 2009 or 2010, there were one district and around 1.9 million people were smoke free. But whereas compared to 2026, there are 282 jurisdictions and 600 million population is declared smoke free, which is very great in number. In the third slide, it's a table depicting the states which are declared smoke free. Like Chandigarh is the first UT which is declared smoke free in 2007. Same goes for Junjun, which is a city in Rajasthan, which is also smoke free in 2007. There are many cities which are declared like Shimla, Shimla, Sikkim, Bhubaneswar, Mizoram. Mizoram is the state which is declared. Himachal Pradesh in 2013 being the India's first large smoke-free state. Very national-wide campaigns are also made done, and all national supports are also being done, in which 13 workshops by the union and vital strategies were done. Then come the results. Legal coverage versus WHO benchmark. India's smoke-free law under the sections of COTPA, section 4 to 10, it is covered under this, in which indoors workplaces, public transports, and indoor public places are covered. WHO rates India's at the second highest there. The key gaps remain between the WHO's and India's compliance are designated smoking areas in hotels, restaurants, and airports, limited coverage of outdoor public places, and exemption from small private below employed threshold. There is also a graph which shows that around 71% are not exposed in public places, whereas 20% is exposed as per the GAT data too. There's also from GAT data 1 and 2, there's data is taken from data tobacco uses prevalence 2009 to 2010 there was 34%, whereas in 2016 to 17 it is reduced to 28%. In homes it was 35%, which is smoke-free household has increased from 35% to 44%. Their public places exposures declined, but at a minimal sustainable margin. There is a subnational compliance in the place like Puducherry in South India. Sections 4 to 10 of COTPA are used, which is smoke-free advertisements, sale restrictions, penalties are covered under that section. In which the key finding, which was found out, was that very low overall compliance were made. Advertisement compliance were at a scale of 19 to 38% only, whereas the places like Devgharo or Jharkhand, which is a pilgrim town, a religious town, section 4 and 6B were applicable, which is smoke-free public places and sale near educational institutions. So a key finding was found out that 50, around 52% smoking is observed in religious places, and tobacco sales within 100 yards of schools at 42% of institution is surveyed. Then there is high risk venues and the enforcement gaps. So the high risk venues are religious places, pilgrim sites, transportation hubs, which are the frequent smoking designated spots. Then there comes the restaurants, the bars, the hotels, which over there are smoking areas designated. Then there are healthcare facilities and government offices, better but not in complete compliance. Enforcement gaps, there's a very low penalty, which is nearly about 200 rupees fine and a weak deterrence. Whereas there is shortage of trained enforcement officers and poor coordination between the people. There is no standards national compliance audits. Conclusion and way forward will be covered by Sir.
So we all know COTPA mostly. The section 4 that stands for prohibition of public places, prohibition of smoking in public places. Section 5 stands for any indirect or direct advertisements that is banned. Uh, the promotion sponsorship is also banned. And then the Section 6A that prohibits sale of tobacco products to any minors, and Section 6B 6B that stands for prohibition of sale of tobacco products in an area which is about 100 yards of any education institutes, maybe the coaching centers also. And as per 6A, actually, the sale by minors is also banned. No, not only the buying, but also the sale is banned. Section 7 stands for mandatory depiction of specified health warnings on pack of all the tobacco products. Next, please. India's tobacco control law is strong on paper, but the compliance is not very strong. Section COTPA Section 4 and 2008 and the 2008 prohibition of smoking in public places rules was meant to protect the people from secondhand smoke in line with WHO guidance. But in practice, national surveys such as GATS to show people are still routinely exposed to tobacco smoke in public places. And why the law that falls short of our requirement? Because there's ambiguous definitions, unclear that what counts as a public place or a partially enclosed space. Then fragmented enforcement is there, that is poor coordination among the agencies which are responsible. Some of the states they have really good enforcement, but most states they don't have very good enforcement all the time, and there is not properly trained staff. Weak penalties are there. Low public awareness of the law and health risks that are also is there. Next, please. And why the second-hand smoke that still reaches India's public places is, uh, though it is by WHO standard, it should be at least 94 compliance should be there. But because of the vague definition, the weak penalties, poor enforcement, and low awareness, the compliance at all the public places is less. Next, please. Close loopholes. We need to close the loopholes and remove exemptions for designated smoking areas. Clearly define the bus stands, the markets, the outer semi-enclosed spaces. Then public education is also required as awareness campaigns. They must be tied to the culture, strengthen the surveys, shift norms against smoking, stronger enforcement, regular audits are required, and leverage technology like larger high risk areas, transport hubs, pilgrimage sites like schools. And schools, they use citizen reporting apps and dashboards. They are now available, like the Tobacco Monitor app is there. Outcome, a law that truly protects health and moves India towards WHO's 94.5% compliance goal. Next, please. So this is for further reading. So this is the bibliography. So you can just go through any study which has been conducted, which has been already conducted, but has been mentioned in the study. Next, please. Thank you. Thank you.
Thank you, Dr. Rakesh and Dr. Kanika, for presenting your findings.
Yeah, Parvi, can you just take the snapshots?
Yes, sir. So before we proceed to expert, our subject matter expert, Dr. Rana Singh's comments, I would request everyone to please switch on their cameras so we can take a group photograph. Everyone, please switch on your cameras. Also, Kanika, if you can just stop sharing for a minute, I can.
Yeah, you can stop sharing. Kanika?
Yeah. Okay, so on the count of 3, bright smiles, everyone. 1, 2, 3. Just take one more. 1, 2, 3. Thank you.
Thank you. So I must have the presence of Dr. Dilip, Dr. Rakesh Gupta, Dr. PC Gupta, and Dr. Siddhi Hathiwala. They are our regular participants, and they are very established public health concerns. And Mr. K.C. Saini is also with us. Yeah, thank you. Thank you.
So thank you everyone for the group photograph. I would now invite Dr. Rana Singh. Sir, he's the Director of Tobacco Control, handling the Southeast Asia region under the Vital Strategies. He has more than 30 years of experience in public health and tobacco control, and he leads and supports policy program implementation, monitoring, and advocacy initiatives to accelerate tobacco control across the region. A very warm welcome to you, sir, and I would request if you can share your comments on the presentation.
Dr. Rana, please.
Yes, thank you, Dr. Rakesh Gupta and team of Sipher for organizing this very important webinar on progress on smoke-free policies in the country. So a critical review, what is the current status and what are their recommendations. So I find many dignitaries and experts in this webinar. So welcome all of you. And thanks also to Kanika Sharma, Ms. Kanika Sharma, for presenting her work, a preliminary work which she has done to assess the current laws, current progress of implementation and enforcement, and the way forward. So thank you very much. So here it's really very important for us to understand why this policy, why policy on smoke free. What is the rationale of this policy? And many rationales have been presented. But most important rationale is public health rationale. It simply protecting non-smokers. Just for example, in India, we have 10 crore smokers, about 100 million smokers we have, and rest whole population, that is 130 million, 130 crore, that is 1300 million, they are non-smokers. So rationale is to how we protect them, and especially the women and children who are at increased risk of exposure to secondhand smoke. So there are many benefits of going smoke-free, and definitely first one is protecting non-smokers from harms of smoking, secondhand smoke. Second is that it also helps in reducing the frequency of smoking. Thirdly, it also helps a smoker to quit. It prompts. It helps a smokers to quit also. And there are many other rationales which have been given for going smoke-free. So now what is the progress? I think Kanika has and Dr. Rakesh Gupta has already shared that progress. India has a legislation, that is Section 4 of COTPA, which prohibits smoking in any public place. We have an enforcement mechanism. Under the legislation, enforcement has been clearly defined. Who are the enforcement officials? How the enforcement will be done? Then how the enforcement squads can be constituted at district level, at sub-district level. Who are the officials at even in a remotest place like a village? How a law can be enforced. So everything has been explained, and this is good part of our policies in the country. Now you see, when India started in 2003, we had a law, and thereafter we had some rules how to enforce the legislation. City of Chandigarh and city of Junjunu, they were the first who came forward and attempted to make their cities smoke free. Smoke free means there is no smoking at a public place. So that were some excellent initial attempts in the country, and thereafter the rules which came in 2008 that really accelerated the enforcement of Section 4 of COTPA and implementation of smoke-free policies in the country. Thereafter, there were many campaigns were initiated by Government of India to inform people, to educate people about the legislation, about the law part, and why these policies are essential. So then, one by one, you saw Kanika has shared that list, a bar diagram, how many jurisdiction one by one they established the enforcement system. Then they done some baseline studies, baseline compliance studies, then underline compliance study, and they achieve high level of compliance up to 90%, 95%. Many jurisdiction even achieved. So roughly this kind of compliance was achieved. Many opinion polls were also done in the beginning, that to assess the public knowledge, attitude, and practice of smoke-free policies. And it was found that in opinion polls that people are supporting these policies. Even smokers, even tobacco user, they also want that public places should be smoke-free. So in that way, many opinion polls, compliance studies were conducted by the government agencies, by civil society organization across the country, and many jurisdictions have been declared smoke free. Smoke free means no one is smoking at a public place. Smoke free does not mean that people have stopped smoking in that city or in that district. So it simply means that no, people are not smoking at a public place, and the communities and the public is protected from second-hand smoke exposure. But still, there is a challenge. Challenge is smoking at homes. How we can protect? So that remained very high in few states. For example, in Himachal Pradesh or in all northeastern states, the exposure to second-hand smoke exposure in GATS 1, it was almost more than 95%. People were exposed to second-hand smoke exposure. In state of Himachal Pradesh, almost more than 82% people at home, they were exposed to second-hand smoke exposure. So it was really very high. I think at national level, it was almost 67% exposure when we had our first GATS, Global Adult Tobacco Survey, in 2009. Then India made some good progress in enforcement and implementation, despite many challenges to that. So the progress you have seen, that many jurisdictions, I think more than 300 jurisdictions have been declared smoke-free. Declaration means a proper declaration by state government authorities, by chief ministers, by health ministers, by the secretaries, by the respective district collectors, mayors. They have declared their jurisdiction, their city, or their district as smoke-free, and informed people that we are implementing, enforcing the law, and people should avoid smoking at a public place. So I think many such declarations have been done across the country, and there are many other jurisdictions which have achieved high level of compliance, even if a declaration has not been done. So they have achieved high level of compliance on smoke-free policies. So this is related to the progress, but still a lot needs to be done in the country. Still, there are cities, districts which are not enforcing the law. First of all, they have not established an enforcement mechanism. Other big challenge is some exemptions which have been given in the law. So under section 4, we can create smoking rooms in a hotel with more than 30 rooms, in a restaurant with more than 30 chairs, and in airports. So these are the exemptions which are not good as far as public health is concerned. Because in public health, we always say even minimum exposure is harmful. For example, if you are protected throughout the day in your office, in at your home from second-hand smoke exposure, and in the evening you go to a restaurant or to travel through a bus or transport, and if you are exposed to second-hand smoke exposure, which is not a public health benefit. So even minimum exposure of second-hand smoke exposure is harmful. So in that way, those exemptions are important gap as far as India's legislation is concerned. Secondly, actual enforcement at grassroots level. For that, penalties are really low, which is up to 200 rupees. So low penalties is another, which they are not a deterrent. Secondly, still many sectors, public places like hospitality sectors, hotels, restaurants, then transport sector, tourism sector. So these are the areas which where still compliance is not as high as in the government offices or in the banks or in other healthcare facilities or educational institution. So hospitality sector, then transport, tourism. These are still some areas. Signages. Signage is very important. No smoking signage or smoke-free signages, they are very important. So we often find that no smoking signage, presence of such signages is also very low, which is important sign to inform public that it is a smoke-free public place. So in that way, there are many challenges. Secondly, even our enforcement is mainly focused on individuals. We are challaning, we are penalizing individuals, but law is very clear. Law has given this responsibility to the public place owner, manager, in charge officer. So until unless the enforcement focuses on public place owners, managers, I think the implementation will not be sustainable. So we need to see that in addition to individuals who are violating the law, public places, because it is the public hotel, there is some manager, there is some owner, so they are responsible to ensure that their hotel remains smoke free, their office remains smoke free, their healthcare institution or hospital remains smoke free. So this is their responsibility. So this is something which we need to ensure while this is being implemented. Lot still, I think a lot more needs to be done in times to come. India is already now law. It's almost now already 23 years of smoke-free policies in the country, and compliance should be 100%. So I was a little bit surprised to see this recommendation that WHO compliance goes towards 95%. I am not aware of this thing which was being shared by Kanika and Dr. Gupta from here, where it has come, because the best policies, WHO says 100% smoke free. So it has to be 100%. Right now, there cannot be anything less than that. If anything less than that means there is some gaps in policies and enforcement. So this is something.
I think it was mentioned only for the compliance studies, not otherwise.
No, but
ideally it's 100%.
So even for compliance, perhaps let me know where it is mentioned that at least 95% compliance to policies should be there. So this is all at this stage. Thank you once again. Maybe any query. So let's hear any questions and comments from the participants and any questions they may have.
Yeah. Dr. Rana, let us have comments from the other public health personalities and
Yes.
mentors also. So, Dr. PC Gupta, please. Any comments from your side, sir?
Thank you. Yeah, it's a very good exposition and presentation. Everybody, we all know about the problems in this. We need to differentiate between compliance and enforcement, because compliance is by individuals, and that depends on their level of awareness and education about law and the rationale behind the law. And the enforcement completely depends upon the authorities. How do they enforce? And that also depends a lot on their own knowledge and education about the law. And not at this enforcement is generally almost always occurs at the lowest level of authority, not at the very high level. And so those are the people who need to be knowledgeable not only about the law but rationale behind the law, because our experience is that when we explain that this by enforcing this law you will be doing your own duty, other parts of the duty, saving lives, improving health, you will be doing more by enforcing these laws in addition to doing other things, and you will be doing it more effectively. You will actually save lives, and that is a kind of found that it's a more effective kind of approach in encouraging and the enforcement people at lowest level to go ahead in a more vigorous way for enforcement. So, and that what Dr. Rana said, that the support for smoke-free places, smoke-free law is great in India. Even smokers, and this we have been, I've been looking at the data for much before the law came into effect, and been publishing also very, very strong support for smoke-free places and smoke-free laws. So I think that is not a major issue. There is only a small minority that would not favor smoke-free public places and laws. So it's a bit of a question of compliance and a bit of a question of enforcement. Thank you very much.
Thank you, sir, for your expert comments. And I actually agree with all of the comments, sir. Thank you. Dr. Rakesh Gupta, sir. You're muted.
My greetings to all, Dr. Rana J Gupta sir, and you all. I have few points to make, definitely. And it's more in sort of where you should include in recommendations what is not happening. And we need to perhaps be more specific when we are saying the workplaces to be smoke-free. We have to also specify, I think the time has come where the apex government institutes and offices, the corporates in India, the hotels, these are three major places where smoking still takes place. And we have not been able to really address these places. Corporates also, to a great extent, although they do have the employee wellness or welfare programs, they have really not been able to achieve much in engaging employees because of two reasons. Many have their culture of the independence and the self-decision. And secondly, they are worried about the attrition. So I think it's very important that in the law, although amendment is waiting for 12 years, we all know that. So how will it happen? I don't know, but our recommendation should include these places to be specified, and also the elimination of designated smoking areas, which I think perhaps in presentations it was not specified. I consider that, of course, everybody has said poor enforcement is an issue. But I think what is the challenge here? And we have a model in Rajasthan, I have been telling repeatedly that PCPNDT improved the birth rate in Rajasthan, particularly in those districts where it was very low birth rate. What they did was that they assigned this work to a police unit which was established in the Directorate of the Medical and Health Services. Until we will have in enforcement, under enforcement for COTPA, the police unit staying in Directorate of the Medical and Health Services doing this work. So it has to be a specific work assignment as a part of the national policy, or maybe again, as we have seen in the modification of the Section 4 of COTPA in 2008, we need to amend it. Because the other agencies cannot keep going there and request police. And police has so many other jobs. But if they have the specified units, I think it will become more foolproof. Second, in policy, I would say that we need to raise the penalties substantially, and we must specify that. And I would say that in any public place or workplace, it should range between 2,500 to 5,000, nothing less than that. Otherwise, the deterrence won't come ever. It won't come ever. The penalties have to be very high. It cannot be up to 200. This is a farce. It will not work. It has not worked so far. Second, I would say that there are a lot of youth who are smoking cigarettes around the vendors. So vendors have to be specifically addressed. And I think both vendors and those who are smoking around those shops should be penalized with 500 rupees fine every time they are caught. I think police will also, and that revenue should go to police. People who are in the maybe traffic police or people who are around, mostly they can do this job very well. And I think there should be police on mobile motorbikes. That I think will work the wonders. It will give revenue to the police department, government, whatsoever. But it will also protect our youth who is smoking around the vendor shops. Thirdly, I will say the quitting is still an issue at the NTQLS and at TCCs. As I have already been saying, adequate resources on a sustainable basis until the quit rates become 50% plus. It won't work. I think that is required even for endgame. I think that the tobacco use should become zero. But until you enhance the quit rates, it will never happen. Keep talking about it and it doesn't happen. I think there is one more thing which should happen through maybe GATS or through the census which is happening now, or NFHS. We are counting through NFHS the prevalence of smoking, but we are not counting in other two, GATS and census, about the smokers in the house. And I think if there are smokers in the house, the enforcement also should extend to the houses. This is the time that, because it is affecting the silent people, the women and the children, the newborn, I think we need to perhaps protect, because government has given enough time to these people, and the people at large are not listening. But all these are sort of controversial issues. One can say that you can talk about the fundamental rights of the people, the right to be there, do whatever you require. But I think that is not right. And lastly, I would say that we had done the meta-analysis, Dr. Sahana Shetia, myself, and Dr. Deshmukh. It was published in 2022, where we had done the meta-analysis for compliance on COTPA. I think that is a reference which you can include as well. And because it gives a sort of collective reference for all the sections of COTPA, the compliance to Section 4 was the highest, except for, it was second highest, I would say. First highest was that sale by minors. I think compliance there is 94%. If I remember, for Section 4, it was around 74%, which was the second highest. So I think that reference should be mentioned. Thank you very much for your time and giving me the opportunity.
Thank you, Dr. Rakesh Gupta, for very valid suggestions.
Thank you.
And I'll request Kanika to please note down the suggestions. I'll just let her know what are the suggestions. And they're really valid. Thank you, sir.
No.
And may I ask Dr. Dilip Acharya to give his comments? Dr. Dilip. If Dr. Dilip is not there, Dr. Siddhi Hathiwala. Yes,
I
Dr. Sidhi.
wanted to say that as we export to electronic cigarette first, it was very
Dr. Sidhi, your voice is cracking a bit. Can you make it clear? Yeah. Yeah, again.
Is it better now?
Yeah, it's better.
Yeah.
Yeah, definitely.
So I was telling about electronic cigarettes. They are flavored, and I was exposed in a running bus. So full journey, I was suffocating. So can't this be included in law? Should this not be included? And same, the laws are mainly seen for smoking tobacco. Smokeless tobacco, the vendors are very close to schools and colleges. That maybe it is not being looked at. So
Actually,
that
we
part
were
also.
in this presentation, we were just talking about tobacco smoke free.
Sir,
So the electronic cigarettes
I
are
am
already banned
actually
in
not able.
India. They are already banned in India. Are you able to listen to me, Dr. Sidhi?
Sir, there is some issue in my network. I'm not able to hear you.
Okay, maybe. So we got your point. Otherwise, yeah. Thank you.
Yes.
Thank you.
Okay. Sir.
Okay.
I have
Mr. Sani, do you have a? Yeah. Yes, Dr. Rakesh Gupta.
small question. Maybe Dr. Rana, you and Gupta sir can respond to it.
Yeah.
How will we penalize those creating the, passive smoking from the vaping? What will happen? Will that be called as because vapors, so it doesn't come under the category of smoke? Or what will happen? Does it get covered under PACA? No, maybe. So how are we going to handle this? This is a very right question Dr. Siddhi had asked, but I think it's a new thing which has come to my mind. And we should consider that as to how are we going to stop this vapors issue who are generating vapors in the public places. Maybe we have not even assessed, but I don't know if there are any research, etc. Maybe Gupta sir or Dr. Rana ji can respond to this.
Dr. Rana, you may respond, sir.
It's already vaping is already it is prohibited at public places. There is a law if someone, but the problem is in the law is that someone using. This was something which was discussed at that time also. So someone using e-cigarette. So right now, use that is not part of the legislation.
Passive inhalers of vapors.
So there is no provision. It's a violation of the law. If someone is smoking, then all the provisions of Section 4 in PACA that will apply.
That is right.
We cannot talk about anything which is banned actually.
Yes,
That
it is a
is
banned
right that,
product. It's a complete violation, and it's a possession. So because the person is using at a public place, so what is the penalty, Dr. Gupta, Rakesh Gupta ji? It's about
1 lakh. 1 lakh is the penalty. Yeah.
So that this case will go in that category.
Yeah.
Secondly, now any study or what is the exposure of second hand vaping? So I'm not aware of that, but I think this is something which can be done.
Yeah.
But otherwise, that complete provisions of penalties of PACA will apply in this case.
Mr. Sani, do you have any comments, sir? Sani, Mr. Sani.
I have a high grade fever, so I am unable to interact, sir. Sorry, sir.
नहीं कोई बात नहीं.
Please take care, sir. Sani साहब.
जी सर, थैंक यू.
और कोई अगर कुछ बात करना चाहते हैं तो अपने आप को अनम्यूट करके अपना वो कर सकते हैं, आप कमेंट दे सकते हैं. डॉक्टर डैनी, any of my interns, if they want to comment upon it. Dr. Kailash is here. Sharing is here. Anyone can comment.
I have just seen in Google there are references, and I'm just putting one reference for second-hand smoking of the vapes.
Yes,
Is
yes.
it Indian studies?
It's an
Is it
American one. American Cancer Society,
American?
American Heart Association, etc. have done this. So good to look at.
Yes.
Thank you.
So if there are no further comments, I think you can have a snapshot of all those presents again, and then we can go to that Thanksgiving ceremony.
Yeah.
A vote of thanks, formal vote
Yeah.
of thanks.
So if anyone can then again just switch on the cameras once more.
Mushkil hai.
So I have taken this snapshot pehle, so I think we'll just share that one. So I would thank everyone for their comments, for their expertise. Thank you, Dr. Kanika and Dr. Rakesh sir, for your presentation on this. A very thankful. I'm very thankful to Dr. Rana Singh sir as well for giving his expert opinion on the problem and the review of it. Thank you to our esteemed public health officials like Dr. Rakesh Gupta, Dr. Siddhi, Dr. Prakash Gupta, and all the others who actually gave their comments on the problem. Thank you, everyone, for engaging and active participation. And lastly, thank you to all our participants who actually took out the time to join us for this webinar. If you have any questions, any queries, you can still present and ask. But thank you everyone for joining in and have a good day, I guess. Yes.
So thank you.
Thank you,
Dr. Preeti. And thank you all for presentation, especially Dr. P.C. Gupta, Dr. Rakesh Gupta, Dr. Rana, Dr. Dilip, and Mr. Sani. So in spite of his fever, he made it, he showed his responsibility to join at least here. Thank you. Thank you. Thanks also.
Thank you.
Yeah, thank you.